Buenos días con todos. Good morning. Welcome from Lima, Peru, to this session. And what a luxury of session to pause, reflect, think, and exchange about global health. Such a powerful concept and construct. And what a better to do that with such a STEAM platform of colleagues. I'm not going to do the introductions for each of you. So the first round, kind of release and practicing, we need to use this thing called microphone. So I'm going to pass the microphone from all the way from Anna to Gemma to introduce yourselves, please. So welcome to Peru, Anna.
Gracias, hola. Hello, my name is Anna Palagi. I am Program Lead for Aging and Health Systems at the George Institute for Global Health based in Sydney, Australia. I think we were asked to give a little bit of a background on ourselves. So I guess I've had a varied background in global health, and like maybe some of you in this room, I come from an NGO background, so non-government organizations. And 20 years ago, actually, I feel like I was implementing both co-design and implementation science methods before they were cool. So I did a lot of operational research linked to the development of eye health programs in the Asia Pacific region, including around task sharing and health workforce development. And we looked very specifically at barriers to implementation, community priorities, in order to be able to design services that best met community and government need. And then fast forward, I think, 10, 15 years after that, I found myself using co-design and implementation science methods in much more rigorous research-focused ways in my work with the George Institute for Global Health. And hopefully we can discuss some of those today.
Thank you for that, Anna. I'll tell the stories of how I got to know Anna. It was through football. So she told me the story of football in Sydney, in Australia. So that's for the teas and drinks afterwards. Over to Valerie.
Hi, my name is Valerie Pasoldan. I'm a Peruvian, Peruvian-American social scientist, work a lot in implementation science for the past 10 years. I've been working on a lot of infectious diseases, started on dengue, I've worked on Chagas, canine rabies, but also moved on to cervical cancer. And a lot of the issues related to implementation science, equity, sustainability, acceptability, feasibility in regional locations have been part of the work that I've been doing. And I look forward to sharing with you all. I'm a member of Cayetano Heredia, I'm faculty, but I'm also at Tulane University based here in Peru. Thank you. Sorry,
well, I'm Rafael Calvo, originally Argentinian, but I work at Imperial College London. I'm a professor in engineering design. And maybe we will get a chance to talk a little bit about what that means, but a lot about what Anna was saying about co-design. So our discipline is all about working with stakeholders and following design processes to produce products, not just in health, but in different areas that best serve the needs of those stakeholders. And at Imperial, we have projects. We have two projects, just to give you an example, on dementia. This one, Impact, here in Peru. And we have another project with the Dementia Research Institute in the UK. And what it's interesting is when we do co-design across the two countries, you can start understanding better the differences between the two socio-technical contexts, but also the similarities. The human needs, many of the ones we've been talking about, are the same here and there. We all have a need for relatedness, not to have good relations with family, friends, community. We all have a need for feeling autonomous, and we all have a need to feel competent in the activities that we have to engage. So listening before to the policymakers, a lot of those things came up. And those are an important part of our design practice.
Hello, everybody. My name is Gemma Hawkins. I'm based at Cardiff University in Wales in the UK. And I work within a research centre called Decipher. So Decipher is a public health research centre that specialises in developing and evaluating public health interventions. And to link into what the others have said, a big focus of our work is how we best develop interventions that are most relevant for the communities that they're being designed for. And at the heart of that are what we call co-approaches, so co-design, co-production, co-creation, lots of different terminology. So that's something that's a particular interest and area of experience of mine.
Thank you, Gemma, and thank you, everybody. So with that, the audience now has an idea of where we come from. And I didn't introduce myself, but acknowledging that we have people online. My name is Jaime Miranda. I'm originally from Peru, and also I work here in Peru for a number of years, and now have dual appointments, maintain my affiliation with Cayetano Heredia, but I'm also the head of the School of Public Health at the University of Sydney. I'm not going to signal who goes first, so but prepare, okay? And I want the first two volunteers to go after the first activities to equalize what's the starting point for this conversation, okay? And the audience today is different from the previous one in the morning. It's a much younger, as you can see in the room. All of a sudden, the age average decreased by 15 years. And I can see the Jen set over there. So we're talking to the youth and various other colleagues, and it's important to not synchronize and not to agree, but to communicate what do we think, or what's in our brains, what's in our minds when we think or when we use the words global health. And I want each of you to go through that reflection to see where we're at, because we're going to throw names and words and co-design and co-production and implementation and research and uptake and etc. But the starting point for all of that will be different. And let's start with my own. And I want all of you to finish, or try to finish your reflection on what is global health with one word. So what is it for you? So I'm giving you time. I'm going to be the guinea pig, so I go first. So I suppose coming from Peru, being trained in the UK, having had experiences of interacting with colleagues in the US, and having seen the transition from tropical medicine here at this institution in Peru, we have a strong trajectory, in-house knowledge on tropical medicine and infectious diseases. Peru as a country, we've seen also the transitions of international connectedness, and we've gone through the ages and eras of cooperation and international cooperation and aid. And therefore the field moved towards international health. And more recently, 20 years ago, not so recently, but more recently, then the world has shifted towards global health. And the starting points, or what was understood in each of these fields, so tropical medicine was primarily to prevent infections coming to rich countries or countries from the north. Then international aid and cooperation was, let's help the poor ones who need to develop. And then global health arrives into that context to try to do things differently. So the word that for me signifies or makes the summary of what global health is, or how we want to do it different, is that it is a two-way street. So global health, different from tropical medicine, different from international health, is a two-way street, which therefore requires reciprocity. So I will pick up that word for me to embed and to bring the core of what global health is. So challenges are there. Where do you start? What's your starting point? And obviously being respectful that we all have different viewpoints, different experiences, different trajectories, and also all of that will inform your connection, your relation with this term, global health. So, volunteers.
Go. Hi. So like Jaime, I was born and raised in Peru, did my education in the United States, and then I did my PhD work in Malawi. So I've crossed countries and borders, and I would define global health from my perspective is we think about each country at different stages of the epidemiological transition, different diseases, whether more chronic, whether more infection, different contexts. And hence maybe the actions that we take in public health are different. They need to be different. And yet I believe, in my perspective, is global health is about cross-cutting issues, cross-cutting themes that we see in health systems in different settings, in different contexts, and what processes we could be learning from each other. You know, what facilitation processes, what questions do we need to be asking of our system? So it's not about having the answers, but about having the right questions and about those cross-cutting themes when we work in these different settings.
Okay. I guess my life story also, though, moved many different countries, and that I'm sure influences some of the perspectives I have. Mostly looking into what are the things that are common to the different groups. And one of the policymakers earlier was saying how we have to support different people in different ways, because we have different capabilities to fulfill our needs. So I guess what I try to do through my job is looking at what are those capabilities, what are the needs, particularly I'm interested in psychological needs, I think are very similar across all populations in the world, but they are satisfied in different ways because they have different contexts and different backgrounds, etc. And that's where the co-design work comes. So global health for me, I guess, it's the emphasis is in, you could say, global well-being and looking at humanity as one thing, no? With parts that have different contexts. But the global for me means we are human. And as humans, we have things in common. And looking for those things in common helps us empathize better, especially because many of the health researchers and design researchers have these global perspectives, if you want. So we need to make sure that we develop methods, etc., to understand those localities, no? Those particular needs of particular contexts. Because like I said, I think psychological needs are common to all of them. So, yeah.
Okay. I'm very conscious of my standpoint, I guess, when I consider global health, and I have to be honest. Maybe 10 years ago, as a white young woman working in Australia, global health meant you were working on projects overseas. So global health was someone from a high-income country getting interested in doing research in a low-income country or a developing country, as it probably was 10 years ago. But my journey has been significant, I guess, in that regard. And to me, global health now is really a focus. It's a focus on equity, on equality, but achieving that through partnerships and equal partnerships, and being, you know, again, looking from my perspective, being very conscious of my standpoint and the role of power in partnerships as well. And I think, like Valerie was saying, I think the knowledge exchange component of global health is really important. So countries, settings can learn from each other. High income, low income, middle income, however you want to label the countries, we can all learn from each other in order to exchange best practice, you know, in order to share barriers, facilitators, all of our learnings in order to really achieve the ultimate goal, which is health equity and equality as well.
So I'm probably a slight outlier in that, as working as part of the Impact Salud project is probably only the second like global health project that I've been involved in. But I think it's something that I've been very excited to do more of, considering a lot of, we talked about knowledge exchange, the sort of transferability across the world, across different places of the work that I've previously been involved in. And I was thinking about reciprocity, and I was thinking about this idea of the connections, but also I was thinking about equity, because I guess there's also, whilst there's commonalities, there's inequalities as well. And so that kind of came to my mind in terms of how the importance of a global health focus in trying to address the inequalities.
Fantastic. And with that, checking in, you and the audience has been able to capture a wide spectrum of experiences and approaches as well. And now thinking on moving on to the approaches, you have the experts in the room. So now is my opportunity to learn. So this first part was to connect. Now it's my opportunity to learn. So I'll start here, Anna, and go all the way down to Gemma. In simple, like if somebody wants to build up on that. So co-creation, co-design, co-production, co-everything, co-benefit. So can you guide us on that transition of the discourse, the jargon, the language, and what it means? And maybe towards that end, we'll end up on the implementation science. So let's try to communicate to our youth and the younger generations getting approached or getting involved in research, how to avoid confusions, how to avoid feeling there's so much information out there, and maybe the essentials and the basics of this term. So I want the terminology to travel all the way here from the cost to the implementations out there.
Please feel free. This is a trick question because, to be honest, I think I'm still confused about all the co terms. I would say my strongest involvement is in co-design. So, this comes after the fact that a problem has been identified, in a sense. So essentially you are sitting with end users, you're working with implementers to be able to best understand the way an intervention might be designed or developed in order to address the problem that's been identified. The co-design I have been involved in, we talk about community, but the community I work with most often is actually government and health workers. So, you often think about co-design as well, sitting with a group in the community and then talking through how to best design something that essentially they might be end users of. But, we also need to consider the implementers of interventions, and a lot of the work that I've been doing actually sort of works with the health workforce or works with governments thinking about policy and policy co-design based on evidence as well. I might pass it on from there so that someone else can start.
You have a lot of good points that you bring up. I would say I always start my talks about implementation science saying there's this figure of this elephant being touched by 6 blind men and or women, and depending on the part of the elephant that you're touching, you might either see a snake, or you might see a tree, or you might see a bat. You're touching the ears, and if we knew that we had a bat in this room and we needed to get it out, we might use, nets, and fly them in the air and try to get the bat out. And if we knew we were dealing with a snake, we might use a broom and push it out, And the importance to me in implementation science before going into the designing process is really understanding the nature of the problem. And I think that a lot of times we think we know what the problem is. We assume we know what the problem is, but we haven't really ensured that all the key stakeholders are engaged in defining the problem. Once we know what the problem truly is from the different perspectives, we do need to move towards that co-design of thinking of how do we now move forward? Because we're not dealing with a bat or a snake, we're dealing with an elephant, right? And now we have all the perspectives on the table, we need to figure out how to move it forward. And it takes a lot of key stakeholders, and it's a lot of times we say, oh, the women are not coming in to get their pap smear and the men are not doing this. No, we have a system that has multiple barriers. And when you say we just need to educate the population and with that they're going to come in, we're blaming, or we're putting the onus, or whatever you call it, we're putting the challenge on the community. Whereas if our systems are not agile and streamlined, we're really defeating the purpose. Those patients or those customers of the system will not succeed. I also think then we talk about implementation science jargon and words. As you said, we were doing implementation science before we knew what it was called. You know, it's important to differentiate the jargon and the words from the functions that we're trying to achieve. And a lot of us are involved in implementation. We just haven't put the right words to it. But I do challenge us to think about what are the functions and thinking about those functions. For good or for bad, yesterday I got a new book in my office, or actually on Friday, called Practical Implementation Science. And I'm so excited to read it, right? Because I'm thinking I've been doing this now for 10 years, but I still don't know all the key frameworks and models and words. And I'm beginning to be more of an expert now that I know those words. What I was really disappointed about, though, is when I looked through the list of authors and contributors to the book, not one from an LMIC, not one, in fact, that was not from Australia, United States, or Canada. Every single one of these contributors to this very well recommended practical implementation science book, and I'm not trying to critique that book, but it struck me because we are walking the walk. We're not in an ivory tower coming up with a jargon and the slang and thinking of the different models and stuff. And I do believe that in implementation science, you have to have two hats. You're doing things and you're programming and you're struggling and you're facilitating and you're co-designing. And then you're taking a step back to think of that research hat. How do I represent it to the rest of the world? How do we make this into a model? And you do have to move between these. And sometimes it's hard when you're in the middle of the mud, thick of the things, to be able to take that step back. But how important it is for all of us to be involved in designing the language, the jargon, the functions, the models, the frameworks. Because if we really want to think about global health, if we really want to be thinking about equity, we need to be listening to all of us in developing this field.
So I think it might be interesting to look at least the designer's historic perspective. Co-design started in Scandinavia in the 60s and started as a movement of the unions who were concerned for the technologies that were being brought to the workplace. So computers were coming in and people there were concerned like on how this new tech will change their jobs. And in Scandinavia, the unions were strong enough that the government brought up legislation that forced employers to have discussions with employees about any new technologies that they brought in. And these conversations between employers and employees were co-design conversations. They had to come to an agreement on what technologies they were going to use. When these practices were taken to the US, so there were a group of researchers in design that moved to the US, they found that these practices were really good at just making better products that people wanted to buy. So a stronger, let's say, capitalist profit-making approach showed that the same practice was effective in creating better quality products. And I think now all of that is also taken into health products that are used in different areas. And the same issues of power relations that we had in the 60s between employers and employees are the same power relations that you see in the health industry. Because the health industry, health tech in global health is also driven by industry, and it's important to take into account the practices that this industry takes. What I find interesting in discussions here this week, and I have had similar discussions in the past with other researchers, is the language that we use between designers and health professionals. So in the last couple of days, we had discussions with many of you about the difference where, if you want, medical research starts. So normally in design, I will start with a lot of co-design work with all the stakeholders I can involve, from the health practitioners, community health workers, patients, older adults, etc. Depends on the context, the particular type of product we want to do. That's very similar to PPI, but public and patient involvement. That exercise of co-design is the co-design of the research that you want to do afterwards. It's prior to writing a protocol paper. A protocol paper is when you understand the problem. So it's related, I think, to what Valerie was saying. So once you understand the problem, you say, okay, this is how I'm going to try to address this problem. And then I follow a very determined, very fixed process. And this is very important because this is how, for example, pharmaceutical companies have been controlled. So they basically don't sell snake oil, and they have to have rigor in the way that they assess, they evaluate any new health tech. And then you do the feasibility study, where you or efficacy studies, and these things sometimes have the same name. So you have 3 different stages, and co-design for the health researchers sometimes comes later in the stage. For us, it's probably more similar to the PPI work, right? So I think it's an interesting discussion to have amongst us, is to try to know what we're talking about, in the sense of like knowing we all know what we're talking about, but I mean, we're talking about the same things, right? Because sometimes we use the same term for different things. So yeah.
Yeah, I think that it is an issue with all the different terminologies, and there's sometimes different words being used to mean the same thing, or the same words being used to mean different things. I think what's important, though, and it draws on what the others have said, is what the principles are. And I think there's overlapping principles, whether we're talking about co-design, public involvement, community engagement, co-production, co-creation. The co is about being collaborative and doing things together rather than 2 or 4. And it comes back to some of the things that the words we use when we talked about global health earlier, in having reciprocal relationships between the stakeholders. And then if we're talking about ourselves as researchers, as academics, and there will be power imbalances and they need to be addressed, but trying to be as equitable as possible in those relationships, and transparent when it's not possible to always be equitable, but sharing that decision-making process as much as possible. And I see a lot of those principles across, regardless of what terms people use. So maybe that's helpful to focus on as well.
That's it, Gemma. Thank you. And it's interesting because for most of you and most of us, and as you, Valerie, Friday, new book coming to your, I suppose it was a printed book coming to your desk or coming to your inbox or your screen. The volume of information that travels and circulates nowadays is vast. And the familiarity, or I suppose the frequency of utilization of these words is increasing enormously. And I rarely see that we make the pause to double check, are we talking about the same? And I think, if anything, that could be a first message for this audience, right? So let's make sure that we're talking about the same. Valerie gave us that unique example of the elephant in the room, and very solid. And what I value from this group is you have people with different life trajectories. So you work on the NGO sector, and you work with a company design as an engineer, and you work with a public funding agency, and your work as a researcher will feed these experiences, right? And I want now to connect with the word that is on the title of this session, is equity. So therefore, and then we'll go into the technology, but don't worry, we'll get there. So then global health, co-design, co-production, framework, experiences, checking in, being collaboratively, or how do we move towards equity? I mean, or in other words, how this way of doing things will be better than the past. So We have tried multiple things. Research has been here with us for a number of years, decades. International research and collaborations have been there for a number of years. So what is hope? I mean, what is the hope of this is the way forward? I mean, what is the benefits of doing things in this way? And let's put the goal of equity out there. Can I start? Go on, Mario, you're good.
Go, yeah, sure. Okay, how do we get to the equity? I believe it's by asking the right questions and asking ourselves the right questions. And as we lead, I've been working a lot on moving the system in cervical cancer care from just thinking of doing a screening to what's the point of screening unless you're going to treat that person, right? What's the point? Do you want to go through a pap smear so that you don't even know what came out of it, or that if you know what came out of it, like you're never going to get to the treatment that you need? So, and we get a lot of pushback from higher level authorities saying, well, they need to go to the hospital and we need to do this. And we're like, but there's no pathologist and there's no colposcopy and there's no oncology. I mean, what do we do? So I feel like the question that we keep posing is, we're not saying what's the best clinical practice. We're saying, what is the most equitable strategy for ensuring that every woman gets a basic minimum of public health care, right? And so, you know, I feel like it's using our voices, our collective voices, to ensure that this is not about Valerie Pasoldan, who's got a phone and can get to the doctor appointment because she can use taxi or a car. It's about thinking about every woman in the most remote and vulnerable populations, and how do we ensure that every single one of us has a right to the most, you know, to a service that works for them within that context. And so equity has been a big part of the work that I've been doing in pushing, because again, in Peru, a lot of decisions get made in Lima, in the Ministry of Health, and even by the hospital level specialists, because the biggest specialists in cancer are not the primary level doctor. It's I'm sorry to say this, but it's the specialists at the National Cancer Institute. But we only have one ININ. We only have one National Cancer Hospital. We have 2 regional ones, and that's it. So for most people in our country, it's really not accessible. And telling them to go to a hospital is really not a reality. So we're basically dooming most people that we tell them that they need to get to Lima to a sure death, instead of coming up with the best way to manage it at the local level, and knowing that it may not be optimum, but we're doing something, right? So I believe when we think about equity, we need to be asking ourselves over and over again, you know, is this decision that we have co-designed, that we have implemented, is this the most equitable approach for as many women as possible? Recently, asking ourselves that question, we're like, okay, we've managed to get screen and treat going in Iquitos, in a rainforest region where the highest cervical cancer mortality in Peru is happening. But it's still not reaching the women in the most remote areas. So talking about technology and mobile technology, we put a gene expert, a test, a PCR, a test that can do rapid testing for women, HPV testing. We put it on one of these boats that navigates the Amazon and the tributaries. We trained the lab people. We trained the doctor on the boat. We trained the doctor on the boat to manage with thermal ablation cases that are not suspicious of cancer.
On the boat.
On the boat. Okay, so we trained in the past, about 6 or 7 women would get a pap smear at every 6-week the boats would take about 6 weeks to go around the circle. They would get 6 or 7 women to get a pap smear, and they may never give them the result. That was the end of it, right? Now, we've had 3 ships that have basically gone out with a gene expert machine on it, where we have tested 250 women, okay, who have all received the result except for 3. Who 45 of them were positive for HPV, and 42 of them received treatment on that same day because there were no suspicion of cancer. One of them was suspicious of cancer. We're going to refer her to the hospital. We can follow up with 1. We can't follow up with 45, but we can follow up with 1. And not only that, but we're taking the care to them, not having them come to us, right? And I'm so proud of this, of this approach, because now the people who work on tuberculosis are saying, hey, can we also put TB cartridges to be used with a gene expert? Can we do HIV testing? Can we go other things? Part of this has been decentralizing that lab. It's not about having everything sent to a lab in Lima, where the person, again, outside of Lima is going to take months to get the result, if they ever get it, right? It's about getting to these remote, it's about thinking strategically about how can we find new ways. We have, nobody uses a landline anymore. We all have cell phones, right? Let's modernize our system as well. Let's modernize our data. Let's modernize our labs. Let's think of new ways to ensure that equity is part of like every question that we're asking ourselves as we co-design and implement projects.
Un aplauso para Valeria. No, it's so powerful, so powerful. And it's so practical example of driving explicitly with the equity goal. So the bar is high. Who's next? Go on, Rafa.
I don't have anything even close to that sort of thing. So
Bring your Argentinian.
let's leave it there for now. No, what I thought it's when I'm thinking about equity in technology, I think there are two aspects in technology design. One is accessibility first, and they have found that thinking it that way, universal access, helps not only because you are giving access to people that otherwise could not use the technology for the benefit of those people, but it's even good for the companies. Because when you design from scratch something that will be accessible to everybody, that means that you have a better quality product. And they have found endless times that it's better to do that first. For example, websites that were accessible at the beginning, they're much, but obviously they are more useful. They're useful for people with visual disabilities, but that also makes them easier maybe to move to a mobile phone type that is helpful for everybody. So yeah, there are many benefits on accessibility first. But an aspect that I think we tend to forget about, it's motivation. Not everybody is motivated by the same things. So getting people to do the pap test requires people understanding why they should do it. It requires maybe a relationship between the community health worker who tells the person to, or suggests to the person to go and do it. Motivation is affected, for example, here, I believe that many of you are maybe medical students or nursing students, health students of health professions. And the way we communicate with patients has a huge impact on how those people will use the health services. And we have been doing some studies in Córdoba, and before that with Latin Americans in the UK. And what we find is that the power distance amongst patient and doctors in Latin American countries is higher than what we were used to in the UK. What that means is doctors will go and tell people they have to do something. You have to take this medication. You have to do the pap test, etc. And they do it in a way that is authority-based. So it's, you must do it because I say, and I know better. But people's experiences are unique. And the only, or the best experts on people's experiences are the people themselves. That's where co-design comes in. It's because you're trying to understand those people's experiences, and they are the only ones who do. As a doctor, you will understand what happens with, a leg, a lung, your ovaries, etc. but you do not necessarily understand much about the experience of that woman or that person, etc. And that's essential for designing, creating services or products that people want to use. There's no point in creating a new tech, a new service, if people then don't want to use it. So understanding motivation is essential. And I think in the Impact Salud project, we're trying to do that by having the designers go to the communities and talking to people. We don't know if people even, for the same reasons you were saying, it's a total loss of autonomy. If you go to a person, you say, I think you might have this thing called dementia. And then, ooh, what do I do with that? There's no service, there's nothing around. So it's a loss of autonomy, because then you're asking me to do something that I'm not in control of, I can't do anything about it, etc. So I think equity requires obviously the existence of those services for everyone, but also finding ways in which people are motivated, driven to use them. No? And that requires also a lot of thinking.
Respond to that. Are you sure? Okay. So there was a recent systematic review I saw last week that talked about, for behavior change, the activity that could have the biggest impact had to do with access. Knowledge, cognitive change, opportunities, motivation were low and medium, but the biggest thing we could do was change access. And it made me think of what you were just saying. When we were testing, we were finding out why women weren't making it to the hospital for their follow-up appointments. One woman had gone 13 times. And the average number of times a woman had gone to the hospital to get her follow-up appointment was 6 or 7 times. And as a result, they'd go one time, you don't have the right paperwork, come back. Now you go another time, yes, now we can make an appointment, but oh, the appointment book for the next month is not yet open. So come another time, go back home, come back the next time. Okay, now we can make an appointment. You get an appointment. Okay, come back for the appointment. Come back for the appointment. Oh, the doctor had an emergency meeting in Lima. Let's make you another appointment. Go back time. And this was the average, 6 or 7 times. So I really think we need to think about access. We think about co-design, not just in terms of products and innovations, but also in systems. We need to design good systems. And the last thing I want to say here is, how many here are Peruvian women? Okay, so I'm seeing how many women are, okay. How many of you learned about pap smears in your high school? How many of you learned about it from your mother? How many of you learned about from an auntie or a friend? How many of you learned about it in the university? And how many of you that lifted your hands are doctors and learned about it in medical school? Okay, so I asked this because in general, if for the ones on tape and couldn't see this, in general, we expect people to somehow learn from osmosis how to take care of their health, whether it's prostatic or breast cancer or cervical cancer, or, we just expect people to be born knowing these things. And how do we expect this? How do we expect people to go get a pap smear if we don't ever learn about it? When I did some focus groups here in a middle income community, women said, I know what it is. I don't know what they're doing to me. I don't know what it's for. Well, that's a problem. Anyway, that's my comment.
Equity, I mean, I think when we consider advances in public health, we have solutions now for some of the world's biggest killers. And the real issue is, how do we get the solutions through to everyone? So the question, as Valerie mentioned very initially, it was, what is the appropriate solution, or what is the appropriate way to deliver that solution in a context? And to achieve equity is really, addressing all of the factors within the context that's going to bring that solution to the greatest number of people who need it. I mean, if we think about cardiovascular diseases, the greatest number of deaths worldwide are from cardiovascular diseases. And we know if we screen for blood pressure, if we catch people early, if we get people on blood pressure lowering medications, we can prevent cardiovascular diseases. It sounds like a simple solution, but how do we get that screening to people? How do we get people to understand they need to be screened? How do we get people then to take medication when they don't feel sick? that's one of the biggest issues, is actually the compliance with medication. And I've been lucky to be involved in an 8-year now project in Indonesia, which is really sort of thought about all these issues, but over 8 years, it's still learning, and it's really centered on a mobile health supported program that brings screening through the community health workforce to village-based communities and to remote communities, and then links those patients with sort of primary and secondary healthcare services. But the biggest barriers that we've come across in that program are actually, ensuring that patients are followed up. So it's a continuous cycle of care followed up through the system. And when people don't necessarily fully understand, again, that if they're not feeling sick, why should they be taking their medication daily for a condition that's not yet impacting their quality of life? It does present a very big barrier to I guess, optimizing health. And that's why this program has been going on for so long. It's because through learning, and we talk about, continuously learning health systems, we're able to identify the barriers to care and actually continually address them through different interventions that would optimize that model. The issue with medication is a major one, and just to comment on that, in Indonesia, for example, and I think it's similar in other settings, so the prescribing of a blood pressure lowering medication used to be limited to 5 days. So someone could go to the pharmacy, get 5 days of medication. If they wanted to continue their medication, which they need to do daily for sometimes the rest of their lives, they would then have to return to a pharmacy to get their medication. You've lost patients after their first 5 days. So by identifying that as a key barrier, we've been able to sort of support policy change in prescribing, and we're up to 30 days of medication prescribing, which still isn't much, but it's an incremental improvement. And it's sort of small changes like this that eventually, we hope, will, lead us towards equity.
I would just finish off by bringing us back to talking about co-approaches, in that I think a lot of the things we've been talking about can obviously benefit from these collaborative approaches to address barriers, to understand how best to provide access, to understand the motivations. But I think there's sometimes a flaw in the approaches that we take, and that we might not be working with the populations that we need to understand the most. And so there's a real focus on, and that's not easy, but to identify and understand how best to reach populations where the barriers may be greatest, where the access may be most problematic. And so it's an essential approach, but it has difficulties within it. And I think sometimes, and especially within some of the work we do in the UK, you end up working with people who are the people who come forwards to be involved in co-design, the people where perhaps the barriers are the least. So it's how you work with the most appropriate relevant populations.
Thank you, Gemma. And Gemma, now I'm going to put you on the spot, because for the next one, the obvious question is then, in this quest towards equity, it's been demonstrated that the world has undergone this rapid and massive transformation of technology. So technology is here to be with us, to live with us, to accompany us, and all the positives and the negatives. So if the statement and if the question were to be, how can technologies will guide us to achieve equity, each of you will have hours to talk about. And I want to focus on the but, because we can all think of the positives and the common sense and the nature, but from your field and from your experience, I want to share that what is the but of, hang on a second, have you considered this or that on the technological side? Because I want to avoid just shifting us in the quest that technology is the holy grail. It's there, it's helping us a lot, but having these different brains, experiences will be would be really nice. So let's start with Gemma. And purposely, I'm going to say, Rafa, you go last because he's professor of technology and design. So he will talk 3 days on the back.
I think I would go back to exactly what I was just saying in terms of understanding technology use within the populations that you want to work with. So I think people talk about the digital divide and how there may not be equity in access of technologies, and which links back to everything we've just been saying. So really needing to understand, I think it's something we've experienced within the impact project so far in terms of where sometimes the internet connection might not work, and that's a really important potential barrier to technology use to understand. So being able to fully get to grips with what the technology could offer, but also how in reality, and I guess that brings us to the idea of thinking about implementation science. What is actually possible for this use of technology? So yeah, where there may be particular barriers to having that access or making the most of it, which kind of repeats a little bit what I said earlier, but I think that's important focus.
Thank you, Gemma.
Yeah, I mean, yes, technology is fantastic. I mean, my but is, but how does it fit within existing systems? And I think I work a bit in Pacific Island countries, and I think there was a term flying around a while ago, pilotitis. And what we're seeing in Pacific Island countries is app-itis. So people will come up with an app. It will be implemented in a small scale program that likely sits outside, the public health system. The app works among 50 people, but then so what? If you think about the sustainability of use of that, it's impossible to sustain if it doesn't fit within the current system. And I think just going back to the work I was talking about in Indonesia, what the focus of that smart health program, which is an app-based program, is that the view has always been on sustainability, and by partnering with the government, what we're working towards, and it's refreshing to see also with the development of the technology and impact, is the integration of this technology within the existing e-health system, and by integrating the app with the ePuskesmas, which is the local e-health system, it simply means that all of the data comes into the one place, and from community health worker to a nurse to a doctor, they can see all that patient data in the one place. And not only can it be used for clinical decision making, it can be used for planning, because it's now in the administrative health data of the province in which we're working. So they can use that through the technology, use that to plan more equitable health services. So my biggest but is, always consider where the technology fits within existing systems.
So I couldn't agree more with comments that have already been made. I keep thinking that there's two audiences that we keep talking about. One is the population, and when we think about digital divide, who has access to technology, who has access to internet. In the rainforest, there are areas where you just really don't have, you still have to use radios. And so there's different challenges at the population level. And yet there are technologies we can use, like social media, TikToks, whatever, to get out there and educate population, or like in our case in Arequipa, for example, we've set up a system on Facebook where people can send a picture of, in the past, what they used to have to do is, if they thought they had the kissing bug, a triatomine in their house, they had to get it with their hand in a bag and take it to a health facility and see if it got to the right person who would say, yes, this is a triatomine and we need to go to your house and check for an infestation because it transmits Chagas disease, right? So what we've done now is people can take a picture of it, send it in a WhatsApp to somebody, and a biologist will look at the picture and say, don't worry, this is just a beetle, or yes, this is a triatomine, we will send a team. So we've facilitated access, and we've also used that medium to educate the population and start kind of helping people identify this bug. So that's at the population level. But again, there's that whole issue of digital divide, equity, and how we use it. Then I think at the systems level, I remember when we started working on our cancer project, when we started analyzing the number of papers that people had to fill out, the obstetras, the midwives in the program told us, we spend 2/3 of our time with patients and 1/3 of our time filling out paperwork. And when we started thinking of all the papers that were involved, just at the health facility, at the primary level, there were 5 or 6 papers they had to fill out. But when we traced every single document that happened at every single stage, there were 67 documents. Okay, there were 67 documents and papers that needed to be done. So you say, okay, let's start streamlining this system, right? But how do we streamline it? We can create apps, but then you don't want to create an app that is a parallel to the system, because yes, it's faster, you're going to get it quickly, but then as soon as your project dies, the app goes down, the data does not become available. So, okay, let's get the right players. Let's co-design a data system that everyone can access. But see, then within the government, there is this group that wants the data because we want to write papers. And then there's this group because they want the data because they want to evaluate the operationalization of their program. And then there's this group that wants to analyze. And so what we've seen is, we all need good data if we want to evaluate a system, and we need to have access to that data. And the data is only as good as the quality, the analysis will only depend on the quality, right? So once again, now I'm thinking of the health system and the importance of using adequate data, using this technology to improve collection of data, good collection of data, integrated data collection. So we're not filling out 5 different apps for 5 different systems, and sharing the data so that you have access to the operationalization, you have access to the data you want for your publication, and sharing it widely. So it's not just that you have access to it, but the researchers who also want it don't get it until you're done writing your paper. And then, so we see that this fight. And the only thing I will say is, yes, if you want to go fast, yeah, create your own app. It will not be relevant maybe in 5 years, and maybe nobody will use it in 3 years, right? If we want to go far as a system, it means we're going to go slower, but we need to get the right people at the table. We need to all share a vision, like why we need the data and how we all really, need data if we're going to really make improvements in the system. And it's not about me getting another paper so that I can have whatever number of publications before I die, versus like, let's work to a system that is working to the health of people. So anyway, I just think that there's those 2 parallels that need to be going on, and the importance of not keep creating, when I first started working at Iquitos, people were like, oh, this is going to be another project. You guys are going to do this. We're going to change everything. And then in 5 years, you're going to leave and it's all going to go back to zero. I understand people are tired. All these new programs come along, change everything for a while, and then it goes back. So yes, go slower, but really integrate it into an existing system so that we can truly make a difference in the long term.
Your turn. So I was going to talk about AI because I think there's a huge risk around equity on particularly that new technologies, not the same as previous technological ways we have. But I think I changed my mind, and that one is important. But before even looking at one particular technology, what we looked a lot in, at least in a course we teach our engineering students, is follow the money. So follow the money, it's where is the money coming from for a particular project? In a research project, what Valerie and Anna was saying before, often people are given money to produce research outcomes. In many countries, those research outcomes are papers, sometimes data sets, etc. That money was given to those people. That's the motivation of those people. In the UK, that has changed significantly. First, because the funders ask us to release the data as open access, publications on open access. but also for universities, what we call the impact of the project becomes essential. It's even worth more for us now as academics to be able to show that we were able to change the health system in the UK than all these 3 or 4 papers that may come up out of this project. And I think that's quite important. So there is one source of money is research funding. And I think that's one of the reasons all these things happen. The Australian Research Council also has the impact. They're introducing that. I think it hasn't become as important as it is already in the UK. But that's a reason why so many people create apps, because it's an easy way to get the data you need for your research, for doing what you were paid to do. So there's nothing wrong. You just need to understand the motivation of those people to do that. The second one is private. I think one of the most impactful technologies is WhatsApp, and really supports equity because you can do it anywhere. It's free. You gave an example there where, so free, I'm putting free in quotes because obviously Meta is not a charity. The reason they do it is because it's part of their business strategy of different things. But it's free, it's secure, it's double encrypted, so it can be used for many valuable things. The other sources of technologies from the private sector that are paid, and that becomes often a problem because they become very expensive. In the UK, NHS, the National Health Service, spends billions on private technologies, and sometimes they buy, now the big fashion is to buy robots or to do surgeries. And they're really expensive, and there is no evidence that they are good for the health service because they're really expensive, and it's even cheaper to get the surgeons to do the surgery, right? So, and that has increased the cost of health service in other places. And the problem is that sometimes our countries look, oh yeah, but all the London hospitals are using robots to do surgery. We should buy robots. No, I think in fact the NHS should be reconsidering using robots. Sometimes they buy technologies for the sake of technology because the private sector makes a ton of money selling those private products. And there's not always value. That's the second source of money. The third source is government. Government, like the people we heard from Minsa this morning, etc., they normally don't have too much money or any money, and they have too many problems. But they do provide services, and we should be helping them have the right services, right products, etc., so they can provide more equitable healthcare. Finally, and the one that I like the best, in Australia, I love that Australia does really well with NGOs. I work a lot on mental health and on asthma and chronic illness, and Australian NGOs are amazing. They get well funded. And to me, they're really important because they are generally community-based. Maybe here, what the Minister for Development and Inclusion does, it's similar in the sense that they're very community-oriented. And that is the source of equity, because the community knows how to best distribute their resources. A central government will depend on the politicians and their, you know, if they're the right, the left, oh, giving money to this group, it's wrong, it's a waste of money, giving money to that one, etc. That will change. But communities know what they need the money for. So NGOs and community-driven, community-based initiatives is the best. I personally think the best case for Impact Salud is to work really, really closely with the Minister for Development and Inclusion, community health centers. That's the best way to achieve equity. Because again, communities know where the sources of equity and the money, so supporting those through private, government, etc., funding, that's the best way to achieve equity.
Really, really useful, because that brings me to the next question. And now I'm going to put on the spot the audience. So if you have questions, I want you to start raising your hands so I can time it. I see one hand coming up. and 2, okay, and 3, 4, and 5. Oh my God. So we have pressure from them, so the pressure will be passed on to them. Let me, before we go into the questions, final ones, the community, Rafa, and for the others. How and then, good examples, I mean, quick answers or quick responses to these. How do we best engage community using technology for achieving equitable targets? So any examples from experience or any thoughts? Or shall we pass on or reflect on that? The reason I ask is because Andrea in this morning put us another challenge. She said, we in Latin America, we keep rediscovering the wheel. So I want to tap into your expertise and your knowledge of community engagement, community co-design, community, and good examples and good, ideas that we can share back. So start thinking about that.
And we saw this in COVID, and the distribution of food was just like you said. The government gave it, and then the government distributed it to the politicians, the municipalidades, and then the boxes arrived to the people who were probably most associated with the politicians. And there was a critique by an anthropologist, I forget who he was, but who said, in Peru, we have centuries of a process of la olla popular or la cocina popular, like this community kitchen concept. And ¿qué? Olla común, la olla común, they have different, names, but where communities that need support come together around a kitchen or a olla, a pot, to feed those who most need it. And this anthropologist wrote, that it was a shame that rather than relying on a strategy that the community had developed centuries ago and that had used and that worked because the community knew about it, they had tried to come up with a different strategy that just favored certain people more than others and didn't necessarily get to those who most needed it. So I think this is the role of also examining how is the community already organized? What are the structures? What are there are a lot of programs. There are volunteers who've worked in communities many years, but then often once you start paying it, the people who get that volunteer position suddenly change because the ones who want pay, there's different motivations for doing it. So I'm not sure there's a technological thing. I often feel that if you really want to engage with the community, if we rely on this versus a megaphone, I think the megaphone may have a different kind of an impact than those who have their little cell phone at hand. But anyway, that's just a comment.
Going back to being Argentinian, no, that's I can show a terrible. No, but it's what was the word that you guys used earlier for criticizing? Argentinians can do some things very well, but sometimes are terrible. Huh? Rajar. So it just came out recently that the community initiatives that went giving away food were taking 15%. So they had all the notebooks where some of these community groups will tell the people for which the food was allocated, oh, no, you have to give me 15% of that. So yeah, regrettably, one has to be very careful. I'm everything for supporting community, but regrettably, the few cases where these things happen brings down the whole system, no, like the reputation of the whole system. I think maintaining very high, strong processes, so these community centers do it right, is really important, really difficult, but I think it's important to consider, how you do it.
So it's transparency and accountability, right? Yep. Would you like to add on?
Yeah, I think really, if you're thinking about technology and in engaging the end user, I think you need to think about what the purpose of the technology is. And often I think in health, it's about providing information. So, particularly if we're thinking about the community or the patient, they're at the end of a WhatsApp or a phone app and it's to get information. I think it's really important to consider where people get their information from before the technology was in place, and then strategically use those avenues to sort of harness technology to enhance the sharing of information. I do a lot of work focused on older populations and thinking about uptake of technology, and particularly in sort of, remote maritime areas of the Pacific or rural and remote areas of Indonesia. Yes, everyone might have a smartphone, but it's not always loaded with charge or with internet. An older person might have the phone there but never use it, and it's actually their family member that they always sort of look to for support, in terms of getting information, or it might be the community health worker or the village volunteer who they look to for support. So I think when thinking about getting technology to people, perhaps it's more about, harnessing what the existing avenues of information seeking are, and optimizing that so that we can actually get that information out effectively.
I think going back to what Valerie was saying and thinking about what's already in the communities and working with that, and if we're looking for examples, something I've been quite interested in, I don't know if there's much out there about how effective an approach this is, but creating, I think the term is like living labs within communities that particularly to support co-design and sort of better improve services is something I've been interested in learning more about. So that might be something worth looking into.
Thank you, Gemma. On that, let's pass the microphone over there. So we have one, you're going to be last, Chris, so there's two there and one in the back. So let's start with this first two and then on the back.
Hello there, my name is Tania. I'm a doctor, a young researcher, implementer wannabe. I have two questions. Maybe you can comment on either one of two. The first one is about technology literacy, because we sometimes talk about technology and we as scientists, we're very much used to learning, right? Like if we need to learn something, I'll go ahead and learn it and I will train. But that mindset is not the mindset of sometimes the stakeholders or the community. And I mean, I can put an example. I still help my parents try to deal with their emails. So even though they have, and with the phones, and they sometimes use the phones for two reasons and two apps, and they still have trouble with those. And I would imagine that is the situation of many, many people. And technology goes very fast. And even for us, we're now trying to understand AI and all this stuff. So I don't know if you had any comments about technology literacy while trying to get technology and technological tools into all the troubles that we have talked to. And the second question is about communication. We are not really, I'm a doctor and we are not very good training in communication, even though we need to talk to people every day. And more so, I think, while you were talking now, I'm thinking you need to negotiate with stakeholders. You need to negotiate sometimes with people. You need to be persuasive and try to get a message that is sometimes complex, but make it simple and make it culturally appropriate. And all of that comes back to communicational skills. But we are not really trained in that. And I don't really see a lot of programs that are like serious about it. You see courses and things, and maybe try to do it on yourself. So those are my two questions. If you could comment in either of those, that'd be great. Thank you.
¿Pregunto yo?
Sí, para.
Ok. Yo voy a preguntar en español, ¿está bien?
Okay, now let's.
Okay.
You're gonna ask in Spanish.
Yo también tengo dos preguntas. La primera es que como jóvenes, yo soy médico recién graduada y he sido representante de la Federación Internacional de Estudiantes de Medicina aquí en Perú. Me gustaría saber, nosotros tenemos diferentes iniciativas aisladas. Hace un tiempo hemos estado trabajando, por ejemplo, en crear un dispositivo para poder medir la glucosa en orina en pacientes diabéticos y en general para hacer un check-up para pacientes como un tamizaje de detección temprana de diabetes. Entonces, creo que durante la carrera de medicina he conocido a muchas personas que tienen ese mismo interés de seguir desarrollando ideas, de seguir desarrollando iniciativas, pero la mayoría de veces quedan solo aisladas. Entonces, me gustaría preguntarles qué nos recomendarían o cuáles son las estrategias para que estas iniciativas se puedan integrar al sistema o que nosotros como jóvenes podamos alzar nuestra voz para mostrar las ideas que tenemos.
Una pregunta. Ok. Vamos a hacerla en castellano. El castellano tiene más sabor. Hubo una idea hace mucho tiempo en la cual yo participé de codirección, co-creación y co-todo de la comunidad con el gobierno. Y eso se llamaba CLAS, Comunidad Local de Administración de Salud. Yo fui una gerenta, ¿sí? Que departía con mi presidenta, que trabajaba en el mercado, con mi tesorera y con mi secretaria. Fue muy interesante. Pero ¿cuál fue el problema? Que a la gente de las direcciones no les gustaba que los presidentes tomaran la batuta. Para ellos era primero malaria, pero para la comunidad lo principal era tener un odontólogo, que no teníamos. Era tener un ginecólogo una vez a la semana. Era tener un médico internista. Y eso no calzaba con ellos. A mí me botaron de la direza por pelear con ellos y decirles que eso no era lo que quería mi comunidad. Y ahí va el problema. ¿Ustedes han visto? CLAS hay poquísimos en el Perú. ¿Por qué? Hay pocos médicos que tenemos esa facilidad de poder entender a la población. Lo segundo, las direcciones regionales de salud, el MINSA, otra vez yo sé que me van a odiar, pero bueno, ¿sí? Ellos toman las decisiones, ¿involucran a la comunidad? No. Y cuando salen estas cosas maravillosas como CLAS, ¿sí? Les da terror que la comunidad agarre la dirección de salud de su propia comunidad. O sea, ¿no tenemos el chip todavía para poder entenderlos? Esa es mi primera pregunta. Ha habido ya una iniciativa, pero a veces esa iniciativa no calza con los objetivos de los gobiernos. Y es acá algo, ok, codirección, co-creación, pero tenemos acá una gran letra que se llama corrupción. Y muchas de esas cosas no permiten que nosotros avancemos, ¿ah? Ese es mi pequeño aporte, ¿no? Estamos, perdón, mi pulmón. Estamos frente a un gobierno que no entiende el problema de la comunidad, o de repente lo entiende parcialmente, pero no los dejan hablar. Ese es el problema para mí, no los dejan hablar.
Gracias.
Y no les gusta lo que hablamos con la comunidad, también ese es el otro problema. Gracias.
Muchas gracias, Luz María. Sí, but we already had three. So let's tackle these three first, and then we'll go to the last two. Hola, doctora, ¿cómo está? Let's do the first three with the panel, then your question, and then Chris.
Okay.
Okay, we have a new word then. No, corruption. Co-design, codex, community, and now corruption. Thank you. But let's start. So question number one, health literacy and communication skills. Question number two, so many things going on out there, and isolation. And then question number three, or reflection, the important one. Okay, all of this sounds good, but elements of power, relationships, priorities, and who decides? Who wants to tackle? So we won't have answers for all of them. Who wants to go with the first one then?
So regarding the health literacy, technology literacy, and communication, I think these all go hand in hand. I think we have a very hierarchical system, and we need to learn to democratize it. In the same way that we've talked about the word reciprocity and reciprocal, as medical doctors, and I'm not a medical doctor, but as medical doctors, the role is not to show how fancy the words that you know how to use are when you're talking to a patient. The role is to communicate to the patient and use their language. There are systems, for example, in the United States where they talk about teach back, like you explain and then they explain back to you. And so you're verifying. That takes a little more time, but you're making sure that the person is walking out with the information they need to walk with. Even without talking about technology literacy, where there are age gaps, know your audience. I have communication teams that sometimes works on certain like flip charts, et cetera. Know your audience. Most people I know this information for the United States, the reading level of the average American is between the 5th grade and 8th grade reading level. So the many years that you spend without reading, your reading literacy goes down. Imagine if you didn't even finish school in a lot of places, and books are very expensive in Peru. So even reading print, print material that is very pretty and fine, but if you don't have prescription glasses, which a lot of people can't afford, you really need it in bold or in very hard print. So it's not just about technology literacy. It's about like, how do we communicate? How do we ensure that we're not just using a pretty poster, but one that has clear messages, easy readability? And there's ways to do this, but I don't think anybody really gets trained on this. And so I think that that's really in the onus of medical schools about teaching about communication. And we saw it a lot during COVID. I hate to say this, but I would see some of my colleagues on TV and be like, your words are just going over it. Let's simplify the language. Let's use analogies. Let's think of ways people can relate to this. And I think that issue of hierarchy relates a little bit to what you were talking about with the class system, which are community operated health facilities where they're supposed to co-operate a health facility. When you have a system, I colleague that when we were starting our cervical cancer project, she said, Valerie, you know what you need to do. Just go and impose it. Just do it. Just tell them what to do. And if you use that hierarchical approach, it might go fast, but it won't go far. So I think that that's like a chip that we all need to change when we think about like communication and working with population.
I've got the second question. Is that all right? Yeah. So this was around isolated initiatives. And yes, I think that's it is a big issue. And this is why I love health systems research and multidisciplinary research, because I think when you have a fantastic idea, measuring glucose in urine, for example, it's a fantastic idea, but again, I'm going to go back to systems, is how does that fit in with the system? And I think whenever you consider an idea like that, one of the first steps, particularly if you're thinking about how, you want this to be used, you can see that it might be an easy way to, to assess blood glucose, for example. How does it fit in with the system? So I would say the first step, before you even think about developing this isolation initiative, is to do an assessment of the system in which that initiative would be implemented. We sort of do health systems assessment where we look at the macro, the meso, the miso, all the 3 levels of the system and the different players, the different resourcing, the different barriers and facilitators that would be there, just to have that intervention actually sort of get into practice. And I think it's super important now. This is again where sort of the health systems research lens come in, is not just seeing initiatives as isolated. So always from the get-go, your first question should be, why isn't this already in place? Because there could be questions about, your answers might be there to start with, and then examining the whole system to work out what are the barriers to it, who are the key players, and then engaging them from the outset. I think having, obviously multidisciplinary teams in that. So you might not just need your clinical people or your laboratory people developing this initiative. You're going to need people who can address some of the other areas of the system along the way.
Maria.
You want to? I would take on the it's really difficult one, but because as a design engineer, we focus a lot on process, right? And you don't go and ask people, what do you want? You have to understand their needs, and that's very different. in design engineering, one of the first things they teach is a phrase from Henry Ford that was, if you go and ask people what they want to move between towns, they will tell you a faster horse. So the car will never have come about. Now, and then there is the complexity of local versus national strategy. So I'm not defending that. I have no understanding of what happens with the class activities. And like I said, I'm totally for community-driven initiatives. I think that's the way to go. But also community-driven has to come together with the national strategy. So it doesn't mean that, because otherwise we split efforts. We have to be, we have to understand that national governments or higher or state governments, etc., have to move many different pieces. So one thing that we do very well across all Latin Americans, Argentinians are experts on that, is division. So one person pulls, or one organization pulls that way and the other one pulls the other way. And then that means that nobody moves anywhere, nothing happens. So one has to be very careful about that. We are, where communities are so split, so divided. I'm very wary of politicians today that go on the media and say, I will never do whatever he says we need to do. That kind of division, to me, well, in Argentina and other places, becomes fascist. You're saying this group, it's one thing, I'm completely something different. If you're not with me, you are against the country, etc. So one has to be very careful with that. So local is really the way to go, but the localities also have to be trained and have to be explained that there are national strategies. We have to address this first, because that's where autonomy sometimes gets misconstrued, misunderstood. Autonomy means that, for example, the autonomy that a doctor is obliged to give a patient doesn't mean that it's going to change the recipe or the prescription because the patient wants it. Oh, no, I want ibuprofen instead of antidepressant. It's completely two different things, right? If you need that, you shouldn't be giving something else. But the patient needs to be explained why he is being prescribed that. And I think that happens at every level. In the relationship between a patient and a doctor, the patient has the right to be explained why to do something. The local governments, local initiatives need to be explained why the national government is doing something else. So I think it goes both ways. The locality needs to understand that they are national initiatives, but the national needs to explain why we're doing that, not the other thing that you need right now. You may need a dentist, but we can't do that because we don't have enough university places to teach dentistry. I don't know, or we don't have enough dentists, or so. But the reason that the local governments, just like the patients, get frustrated, disengage, and create conflict is because they're not explained. We don't understand why you're doing that, so we think it's corruption. Maybe it's corruption. We are also very good at that, regrettably. But it might just be that they're not explaining to you because they feel that they are in control, they are in power. So I don't have the right. I don't have the need to explain to you. That's the mistake. It's not always that there is a lack of the wrong strategy, right? Or the wrong provision. Is that, well, I can't give you that you're asking me, but then you need to explain. I think that's a lack of leadership. Our leaders need to be told that. And when we have leaders that don't do it, well, we know what to do. Yeah?
Maria, you need to make because of there's people online. We'll continue that on coffee. You have 2 more questions and we're expecting more time. Yeah? Falta un micro. No, toma.
Uno de los micros donde salga ahí. Pero necesita...
A ver. Bueno, buenos días, distinguida audiencia. Para mí es fantástico estar presente en esta sesión. Me ha encantado. Soy Diana Rodríguez, ex profesora Cayetano, médico internista y geriatra. Estaba planteando primero un pequeño comentario y luego pregunta. Estuve leyendo hace poco sobre Alzheimer, siempre leo, pero esta vez leí un poco por qué es más frecuente en la mujer. Ajá. Aparte que vivimos más y que somos más viudas que viudos, leí algo bien interesante, la herencia, las enfermedades crónicas no transmisibles como factores de riesgo, el síndrome de Down, pero algo interesante leí, aspectos socioculturales. Y dentro de esos aspectos socioculturales, no debo esperar que mañana cumplo 60 años y soy adulto mayor y de repente voy a venir al Alzheimer. No, leí que todo esto empieza desde la niñez. Leí que las niñas tienen que tener la oportunidad de ir al colegio y hay menos colegios para niños, una especie de discriminación, de separación. En consecuencia, eso repercute. ¿Por qué? Porque la niña no va a hacer sinapsis de sus neuronas, no va a haber estímulo cognitivo y va a estar siempre en desventaja. Luego crece y se va a dedicar a las labores de la casa y viene lo que pasa en nuestros países y en otros de Latinoamérica, el feminicidio, y entonces recibe golpes en la cabeza. Y también se ha visto que esos traumas pueden ser un factor de riesgo para el Alzheimer. De manera que, ¿será acaso que tengo que ligarme con el Ministerio de Educación para que cree más escuelas y hablemos o cumplamos con el criterio de equidad? Punto 1. Punto 2, voy a ser breve. También leía, ¿y qué pasa con la vivienda? Yo hablo de la zona rural, que la conozco bien. Mi familia es de Huancayo, origen. De manera que hablaban de la zona rural y las cocinas con leña. Y cocinar con leña contamina el ambiente y todos esos pobladores, ese gran salón, que sala, comedor, dormitorio y cocina, inhalan ese aire de cocinar con leña. Y también que leí que está relacionado con Alzheimer. Claro que se ha hecho un proyecto de las cocinas mejoradas, una chimenea que sale hacia afuera para que el humo no contamine la salita. Pero ¿será que sigue ese proyecto? De manera que yo decía, lo dijo el profesor, que sí se están tratando de conectar con gobierno, con el Estado, porque quizás, pregunto, ¿o será ya un sueño perdido, una ilusión quebrada? Exigirles subliminalmente o un poquito más que subliminalmente que cumplan su función y que el porcentaje del PBI que asignan a educación, salud, vivienda sea un poco mayor, porque yo creo que sí hay dinero. Yo sí sé que hay dinero. De manera que esa era mi preocupación. Y lo otro, ¿será que los esfuerzos, mencionaba alguna doctora previamente, ¿será que los esfuerzos deben sumarse? Yo he escuchado, y hay un doctor de Cayetano, el doctor Mauricio León, lo conocí como alumno, no sé si se acordarán, yo creo que sí. Él dirige la Liga contra la lucha contra el cáncer, y lo que yo veo por redes, que tiene su camioncito, tiene su móvil, su casita rodante, donde va a lugares rurales y conecta con los doctores de la zona para hacer lo que estaban mencionando la doctora, despistaje del Papa Nicolau para detectar el cáncer precozmente. Y entonces, ¿será acaso que aquellos que están en algún nicho laboral o que son un foquito, una cabeza de alfiler, que están en diferentes escenarios de este país tan grande, se puedan unir para sumar esfuerzos y no se diluya la acción? Pregunto. Muchas gracias. Muy amables.
Cris amablemente ha decidido pasar su pregunta. Okay, last question, comment and then reflections to close this panel. Okay, go on.
Yeah, thank you. Really interesting points and really interesting questions. And I'm not a neurologist, so I won't go into the Alzheimer's too much. But yes, I mean the modifiable risk factors is, you know, there's very strong evidence now around modifiable risk factors for dementia. and obviously Alzheimer's and that aspect of education, from birth really. So, taking the life course approach. So yeah, education being one very important component. And so, I mean, yes, it comes back to equity. I mean, we have this evidence now. And I think the move and the evidence again around multi-sectoral approaches to health. So health doesn't just sit in a health clinic or with the Ministry of Health. Health, is linked to housing, it's linked to education, it's linked to social inclusion, it's linked to water and sanitation. So definitely, I mean, I think, yes, we need to be engaging multiple sectors, in health, badged health programs. But I think, in order to do that, it is a process to have that knowledge exchange and that understanding. And I think this is where evidence comes in. This is where advocacy comes in. Probably a strong role of some of the advocacy organizations that need to work with government, with politicians, with others, just to sort of enhance their understanding of the links, because to many it isn't obvious. I mean, we work in health, we work in research, and we know the social determinants of health, but it's not something that might be is widely accepted among the public. So yeah, I think that's my comment there. Is definitely, I think that shift towards multi-sectoral approaches to health is really important, and particularly considering the equity considerations.
I will only add to what you said. Agree, the multi-sectoral approach. How do you create that multi-sectoral approach, especially in a place like Peru, where we've had, 8 presidents or 6 presidents in 8 years, and we've had 16, 17 health ministers in 8 years, and we've had every minister change is also a change of the coordinator for, health and blah, blah, blah. So I do believe that one way to move forward is to create working groups that are partnerships between academia, between government, between NGOs, between, grupos de trabajo, working groups, where people who are committed to working towards something, not just being spectators, but where we can create these working groups or communities of practice working towards the same mission, so that when that Minister of Health changes and this other person changes, we can continue having a long-term plan and long-term vision. I think one of my concerns is when you think about issues that are really important, like climate change, et cetera. These are things that people keep pushing behind. Well, 5 years and 10 years and 20 years. I'm Minister of Health today. I'm going to be here for 4 to 6 months. That's usually my lifetime. So what can I do in my 4 to 6 months that will leave an impact and give me a good legacy? They're not thinking about climate change. You're thinking about like a very quick and dirty thing. And so as a result, the biggest issues, the most important issues kept getting pushed behind. And I do believe that if we keep relying on the system as it is, we're going to fail unless we start saying, okay, we know that's a current problem. To build these multi-sectoral groups, let's get government and that way, even if one person changes, the next person comes in and forms part of the group, not leads it, because when you leave, your leadership will leave it with, but it's led in a more democratic, collaborative, reciprocal way, so that the players may come and go, but that shared vision of that working group remains.
Well, to close on a positive note, what I see now, at least in the UK, it's with the technology design. For a long time, technologies like kitchen technologies were designed in a very biased way, regrettably disadvantaging women. I think in health tech, that's beginning to change. There is a lot of a very strong movement for what they call femtech, feminine technology. And at least in technology design, we are not there yet. There's a long way to go, but there is an acknowledgement that health technologies, female health was sidelined for way too long, and designers have a very important influence in that, and that we should be doing something. So students and companies are focusing more on technologies that take into account for women. That's not always a technology specifically for women, but for taking women into account.
Yeah, I think recognizing in, I guess, all of the questions that have come up and what's important, maybe it's not a negative point, but maybe a realistic point, is that in these collaborative approaches, they're not like a magical answer, and there are limitations, and sometimes we have to be critical and recognize the limitations, and where sometimes, as hard as we may try, they may not, fully provide us the answer. That's very important for us to consider and take collaborative approaches. But yeah, they're also not, this will magically make everything better as well, and we should be critical with the way that we use them.
Yeah, on that note, I have to close, and what a luxury of a space. I was only imagining that this conversation could happen in a pub. It's so beautiful, so many. Yeah. Andrea was telling yesterday that in France, midday sessions are come with wine. So, no, but it's importantly for everybody, it's like coming from different angles, coming from different perspectives, coming from different trajectories. I can only see that through the lens of global health, we've been able to unravel and unveil many critical concepts, all the way from co-creation, co-design. I won't use corruption in here, but all the way to implementations, its advantages, but also being cautious on how not to do it well, being critical, and the role of technology. And what a pleasure to have people with diverse experiences and failures and mistakes and lessons to share. So, and importantly, how we see the same thing from our own specialties as well. So we all invoke the word multidisciplinarity, but working together also means those trade-offs of having to be able to listen and make a pause and not just because we're all academics, we are all right by definition, aren't we? Except me in my house. So I think it's been quite a pleasant trajectory. So rather than having questions and answers, kind of seeing and connecting with your expertise, with your backgrounds and with your point of views, with experiences all the way from Argentina and Iquitos and Loreto on the Amazon, all the way to Indonesia and the Pacific Islands, I can only say thank you. Thank you for being with us. Thank you for sharing with us. And thank you for from this cross-learning. I can only finish on behalf of the Impact Salud project that today technology has enabled us that work access. So in addition to all of us in this room, around 50 people prior in the morning, 50 other policymakers, stakeholders. Yesterday we had 150 participants connecting online, including caregivers, people living with dementia, and many others. So something to be proud of, and let's carry on. On the optimistic note, so maybe in 5 years' time, the conversation should be different than the one we're having today. Maybe we can have some more practicalities and lessons on the many concepts and on the implementation side. Maybe we can decrease the presence of corruption, and maybe you can enlarge this table of people to share with and bring the community on board more effectively. So let's stop here. Most of the Impact Salud team will go on to a trip to Iquitos. So reality check. So Valerie will be the go-to person to find out that beer. And thank you everybody for joining us. Un aplauso para los ponentes, por favor.